Hey friends, this episode of The Fellow on Call is not meant to be used for medical advice and is intended for educational purposes only. Patient information has been modified to ensure privacy. The views expressed in this episode do not necessarily reflect the views of our employers. Enjoy! Welcome to another episode of The Fellow on Call, the HEMONG podcast. We're coming at you from Willow University Medical Center. I'm Ronak.
I'm Vivek.
And I'm Dan.
And in today's episode, we have a very special guest joining us today. We are interviewing Dr. Titilope Fasipe, who is the co-director of the Sickle Cell Disease and Thalassemia program at Texas Children's, and she's also an assistant professor in the Department of Pediatrics at Baylor College of Medicine. And not only is Dr. Fasipe a practicing pediatric hematologist that takes care of patients with sickle cell, she herself has sickle cell disease.
This is such an important episode for everybody to listen to because you get a perspective from somebody who sees it on both sides of the spectrum. And we really learned a lot from our discussion, and I think all of our listeners who will learn a ton as well.
Yeah, I thought it was a great conversation. Let's get into it.
All right, guys, let's roll that show. We're so excited to have another special guest on our show today. This time we welcome Dr. Titilope Fasipe, who is the co-director of the Sickle Cell and Thalassemia program at Texas Children's and an assistant professor in the Department of Pediatrics in the section of Hematology Oncology at Baylor College of Medicine. Titi, welcome to our show. We're so excited to have you here with us today.
Thank you, Ronak. I'm excited to be here. I am very much interested in seeing how this goes, but yes, I'm excited.
So Vivek had heard you speak a few years ago at Ashapalooza, which is a big event that takes place during the ASH annual meeting every year. And he was like, we have to get her on the show. And so we're so glad that we're able to do this. And we're excited to hear your story. The way that we start every episode, as you may be aware, is we like to ask our guests one fun fact about themselves. So I turn it over to you. What's one fun fact about yourself that you'd like to share with our listeners?
There's so many things I was thinking about. I was like, oh, should I tell them I love musicals, which is true. Right now, I'm a Netflix junkie, which is sad, but true. I grew up being a PBS kid. My dad always watching all those type of things. So I grew to love musicals and a lot of that. So that's something my family and I follow, like Broadway and musicals. I don't know if that's fun enough, but we'll go with that one. I usually used to do perfect. The cop out of, I was born in Nigeria, but is that really a fun fact or just knowledge? Facts? But yeah.
Do you have like a favorite musical? I imagine that's kind of hard to choose.
As a child, my very first video cassette that we owned was The Sound of Music. So it has a place of honor, but I would probably say I love The Music Man. I love Seven Brides for Seven Brothers. There's quite a few that are on my love list, but Sound of Music has this place of honor.
Some of those are deep cuts. I was thinking,
yeah.
Hamilton.
Oh, do you want me to say Hamilton?
Yeah, exactly.
Hamilton is very exciting, but you need to earn that spot.
Yeah. It's a newcomer. You know?
It's a newcomer. But yes, I did get to enjoy Hamilton actually.
Well, that's great. I don't think we've ever had a guest talk about musicals on the show before, so it certainly has opened up a new door for us to explore. I know that when you said Netflix, Vivek sort of lit up because he's also a Netflix junkie amongst the three of us, but I'm glad you took us in a slightly different direction outside of our comfort zone.
So I'm also a musical theater person, believe it or not.
Okay, Vivek.
Yeah.
Tell us
in
more.
college, we had the student-run musical theater organization. I did a lot of stuff for it. I played in a lot of musicals, Spring Awakening, Rent, did the sound design for most of them. So I've got some musical theater stuff running. Like, you didn't know that about me.
No, I didn't know that about you. And, this was supposed to be a fun fact about Titi, but here you are.
I know. I took over the conversation. So, yeah.
Before we let Vivek's ego get too big, let's dive right into this. And I think I want to kick this off with the first question. Titi, we brought you onto the show specifically because we had heard your story about being a physician that takes care of patients with sickle cell disease, specifically children with sickle cell disease. And it's our understanding that you yourself have sickle cell disease. And so I want to open up the floor to you. Can you tell us a little bit about what it's like to have this diagnosis, what it was like growing up with this diagnosis, and how this has shaped your framework as you transitioned into becoming a physician and now taking care of people that have the disease that you also have?
Thank you, Ronak. I first wanted to say thank you to the three of you for being so thoughtful and your communication with me, and also just the fact that you want to prioritize sickle cell disease in this way. So I feel honored to be here. It's hard to describe. So I was born in Nigeria. I mentioned I'm a Nigerian American, and my parents did not have newborn screening. So they found out I had sickle cell disease when I had my first pain crisis, and they just couldn't figure out what was going on with me. So they took me to the hospital, and that's when that test was run. So I was probably close to 1 year old when that happened. Fast forward, probably my earliest memory was when I was like early childhood, 5 or 6 years old. I just knew I always had bouts of pain and I'd be miserable. Most of those bouts of pain we managed at home, but I do have some early memory of a hospitalization as well. And so being born with the disease, for me, like many people with the disease, you first define it from the pain that it causes. But there were some other features of the disease that I already knew about myself. I'm the slower one, I'm the small one, I'm the this, I'm the that. So I always felt different. I'm the only person in my family with the disease in my immediate family. So the sister that's a year and a half under me, she was like taller than me. There were just so many things that I realized that, okay, I'm different. So the pain experience is one, but just the experience of the fatigue that comes from the anemia and the slow growth or the constitutional growth delay, all those facets, they impacted my life more from the experience side. But I would say I had a happy childhood in general, but it was certainly a constant factor in my life that I was always aware of. Let me pause there because I could run off on each of these questions so much, but I want to make sure I captured what you were asking. But I would say that I was born with the disease. It's just always been a part of me. I don't know anything else but this experience.
So one of the questions that always runs through my head is, can you tell us about being born with it, having these pain crises early on, noticing some of these, the fatigue, some of these differences? How did that change as you got into teenage years, from going from, being a kid to a teenager and then into your early adulthood?
So I will say that when you talk to various people in the sickle cell community, it does not always match maybe what the doctor's version is. Doctors, our experiences impacted by the most common presenting type of patient, but that doesn't necessarily represent the general population. So I believe many hemonc doctors on this that follow this podcast may or may not know that the majority of people with sickle cell disease actually do not present to care for various reasons. So the ones you do see in the hospitalization, it's like this is their last rope. This is what they feel is like the last effort. And I was certainly raised in a family that we would prioritize home management of my disease over hospitalizations. And so I was also raised in a family that the be all you can be kind of concept. I never felt that I shouldn't, even though I knew I was different, my parents never made me feel like that difference was necessarily a bad thing. And in fact, I slowly learned that there were some things about me that as a young child, I would attribute to my sickle cell disease that were positive things. I was a more of an introverted type of person, and so a shy person, and the goody two shoes type of person, but part of that was because, I wasn't going to go jumping off about it. Now, you will find that there are thrill seekers in the sickle cell community space as well. But my experience was more of a quiet homebody. So I didn't necessarily felt like I was being cheated on life at the forefront in those early years. But yes, I did question why I looked different. I did question self-image was a feature growing up, especially when I got into the teen years. It was some of those things that maybe we would consider superficial now. Those are the things that stand out to me. Like, I wish I was prettier or not as gawky looking. I wish I didn't feel so tired all the time. And everybody's doing that water-based activity, and I'm staying away from it. And I don't know, some of the limitations I created for myself. It's not like a doctor said, don't do it. I was just like, well, I have sickle cells, so I'm not going to do that. I would have severe pain crises about 3-ish times a year, and many of those would still be managed at home. But when I was 6 years old, there was one that my parents, I just couldn't be consoled. And so they did take me to the hospital, and I ended up spending about a week there managing a pain crisis. And like, I can count on my hand some of these isolated experiences of when I had to go to the hospital. But the severe pain, I would push through it. I knew it would go away eventually. So we had a regimen, prayer, singing, various things until I would fall asleep. And when I woke up, things were better. In college, because I think you asked me to kind of go through the little lifespan changes. So it was like an old hat. I knew my sickle cell, okay, bad pain sometimes, and certain things put me more at risk, if I didn't get enough sleep, all those kind of things. I remember missing a biochem test because I stayed up all night studying in a series of staying up all night, and I had to pay for that later. So I missed the exam and I had to retake it later. When my gallbladder had to come out, I missed another exam. And my last defining experience in college was getting aplastic crisis. So most people associate aplastic crisis as a pediatric phenomenon, but I had never been exposed to parvovirus until I was about 21 years old. So it was right before my 21st birthday. I thought I was dying, actually, because it did not feel like sickle cell. It wasn't painful in the same way. I just knew I kept on getting tired. My head was pounding. And by the time I ended up in the hospital with a hemoglobin of 2 or something, I did think that this was it, that this was my it moment. And so let me actually end on that point. The constant feeling like, am I going to die? That started happening in my teenage years because my mom is a nurse, a retired nurse. And when I looked at her textbooks, it would say, lifespan of sickle cell, 18 years old or something. And our interpretation of that, many people with sickle cell, their interpretation is that it's that finite. So I would be, as I was approaching my teen years, or as I was in my teen years, I literally felt like there was a clock going off and I would die. I didn't know how it would happen. So when I had the aplastic crisis episode, I was like, oh, here it is. This is how it happens. I'm going to just die because my time has come. So let me stop there. So that's like my young childhood and adulthood. There's a few, well, I can go on, but there's a few nuances to managing it. So childhood, school is easier. You could get school excuses. You can, do that. College, I had to figure out how to be a better advocate for myself. And I did not engage with the Office of Disability, which is what I encourage college students to do now. I didn't have that sense. Nobody taught me that. And so then in more of my middle adulthood, if you will, I'm 43. I'm 43, I think. We'll see. I'll count back in a second. But in this phase of adulthood, I've realized that since becoming a resident, since becoming a fellow, since becoming an attending, I've had to figure out what does it mean to be responsible to my job and the people that are looking up to me, patients, and what does it mean to prioritize my health and balance that. So let me pause there and see if there's any other spaces you want to go to in that.
So, one of the things that is really striking to me in what you said is that you would manage a lot of these pain crises at home as you were younger. And I really want to ask about maybe not the reasoning behind that, but what your interactions were with healthcare providers. Let's say now that a lot of the patients we see in the adult hematology side, right, they might be in their 20s. We do see some younger patients, their 18s, early 20s, mid 20s, who are coming in with pain crises. Can you tell us a little bit about that experience, having to tell the ER doctor that you're in pain and, just what that was like for you?
Yeah. So let me start from the place of part of the definition of pain. For me, pain is suffering. Pain is a version of suffering. And so whether you're going to say emotional pain, spiritual pain, physical pain, it's a component of suffering. And I think you have to have that realize if somebody's complaining of pain, whether it's a migraine, labor pains, whatever it is, you broke your ankle, they are suffering in that moment because of those feelings. There was something that started happening when I was older. So, when you're young, everybody rushes to you. You cry, people rush, pediatrics, we're giving you lollipops, candy, we're doing all sorts of stuff. But there's something happens when you're no longer cute. So you're a teenager now, you're not the cute little chubby cheek cherub thing. And people respond to you slightly differently. And this even starts from your own family or friends. The first time your family member tells you, are you really that bad? Or is this, once somebody questions your experience, you start to feel concerned or bothered by that. So you wonder, okay, if I know I have to convince my mom or doctor or whoever that I'm in pain, what does that look like? Because whatever I'm presenting right now does not appear to be enough for them to believe me. And so as a teenager, I already started to notice that the help people used to rush and give me when I was cute and young, it wasn't as prominent. So I started becoming or attempting to becoming more independent. I would have tricks in my mind, like as in tips where I'd be like, well, let me keep my medicine close to me because I don't want my sibling to complain about having to wake up in the middle of the night and go and get medicine. Like I didn't like the feeling of being a bother. I don't think anybody intentionally wanted me to feel that way, but I definitely felt different than when I was a little kid, where people would come, rush, rub my back, be there to me till I fell asleep. I didn't have that experience consistently as a teenager. So by the time I was in college, I already had this like concept of an emergency kit under my bed. I didn't want to ever feel stranded. I stopped trusting that I could depend on anybody to just be there for me. All right. So let's talk about how you interact with the healthcare system. There is a myth called good sickle cell, and I fit into that bucket. So, of course, the doctors that I did interact with, okay, I'm going to have to go there really quick because you guys, I have to parallel the Black experience with the sickle cell experience just a lot. We'll see. I already had the experience of being a Black person in America and being a Black person in Nigeria. Of course, Nigeria, most people are Black. And so I could tell that I was considered a good Black person. I didn't know when I figured this out. Was it because I was a straight A student? Was it, whatever it was, people liked me, but they liked me better than some other Black people. And I didn't understand all that dynamics back then. I just knew it was a thing, teacher's pet, whatever. And I could see I had the same effect on doctors. They were like, are you sure you have sickle cell disease? You probably have sickle cell trait. Like I would get that a lot from doctors. And it was a weird backwards compliment insult, meaning you look too good to have sickle. How are you in college? And of course, my hemoglobin is a 7. I match the biological characteristics, but I realized they were expecting to see somebody different, whether that was somebody more disadvantaged, less academically performing. I don't know all the aspects. And so I think sometimes I didn't see the full picture of the medical lens until I was an adult. So my first experience was actually a patient, not me, myself. I was in my internal medicine rotation as a third-year medical student, and I'm MD PhD, so third year as in quotes, like when I came back to the clinical years. And I saw a young woman, she was about 26, so about my age at the time, who came in with sickle cell pain. And I saw her diagnosis, so to me it made sense. She's in a pain crisis. But I saw that my senior resident and the ED professionals, they were struggling to believe that her pain was real. That was my first experience in realizing that sickle cell is ugly in America for some reason. It's ugly everywhere, but the American lens seems to be wrapped up somewhere in this space of race and advantage and disadvantage. And to quote a sociologist, whose pain matters. And so I was like, why wouldn't you believe she had sickle cell disease? Now, this woman was homeless. She had 3 kids. She had a lot going on. But I couldn't understand why they would question that. And they insinuated that, of course, she was drug seeking and all this other stuff. I convinced them to admit her. I was like, please believe her. I was like, I see your resident, please believe her. So they're like, I'm sure there was probably way more biological reasons why they admitted her. But in my mind, I convinced them. So they admitted her. She was there on the floor. But there was lots of problematic conversations about whether she was faking it or not, all this kind of stuff. I didn't have that experience for myself until, let's say, was I a resident? No, I was a fellow, actually. I went to an emergency department that was in a smaller town. And, well, there's a couple of instances, but both of these instances happened when I was a fellow. And I could tell that the people doing my intake, it was like, the eye roll, oh, she has sickle cell. Oh, and you just already feel like you're a problem. People have communicated to me their experiences and they're very similar. They will see people literally roll their eyes. They'll ask them questions that I don't know if you would ask everybody else. And the main take home point that I'm trying to make is I don't know if the pain of sickle cell is always believed. And I can't always tell you how many people with a migraine or with other types of pain, let's talk about functional abdominal pain, anybody who was a resident and took care of that, where it's hard to figure out the disconnect between what the patient is saying and what you want to manage them with. That happens in various diseases. And you figure out a way to talk to the patient, work with the patient. But I hope the patient isn't getting the sense that the doctor or the care team doesn't believe them. But with sickle cell, it's definitely the rule where you're less likely to be believed, or you have to prove yourself to be worthy. I don't want to tell you I'm a doctor before I get good care, but sometimes I have to play the doctor card, or my friend, anybody who comes with me, an advocate, plays that card for me. So yeah, it's quite problematic in that the experience of most people in the emergency department that has sickle cell is one where the emergency department team does not believe them, or they're frustrated that they're there, or there's a disconnect between how they receive care. I'll just say that I understand there's many layers. I hinted at race, but it's more than just structural inequities and structural racism. There is this implicit bias that plays a role in sickle cell care that is ingrained in the medical community space. And to the point where you're shocked when a doctor is nice to you, which is sad. But like when doctors have been nice, I'm like profusely thanking them, because I'm like, well, it's almost like, thank you for believing me, or thank you for trying to take care of me. Yeah, let me stop there.
Yeah, it's interesting. I have had that experience where patients seem just disproportionately grateful when I'm working with somebody, and I've had experience with sickle cell disease, and like, thank you for being familiar with it. And it makes me so sad that like this is the bare minimum like interaction to have with the doctor is considered extraordinary. And I also found it interesting that you said, as you're becoming a teenager, you realized you had to change how you transmitted how you were feeling, because, and I think that plays into all of this too. The folks with sickle cell disease have such a high pain tolerance from a lifetime of these pain crises that pain doesn't look the same for everybody. And that especially goes for folks with sickle cell disease, and for something that we don't have a test that can prove this is going on. I guess the question I'm trying to get to is, how can we best counsel our colleagues when we do work with folks in the emergency room, and maybe we witness a suboptimal interaction between an emergency provider or another provider, just not emergency, not going to single them out, and as a patient with sickle cell disease? I just don't know how to approach that.
Mm-hmm. And this is a great point, Dan. So there's an asterisk. I now know several wonderful emergency department physicians who love sickle cell. They love it. Like, they are champions. Again, I was blown away when I met these people. I kept on touching their heads to make sure that they were real, but they exist. And the same way we have the American Society of Hematology and some of our other large hematology oncology physician groups, American College of Emergency Physicians exists for the emergency department. And some years ago, both ASH, American Society of Hematology, and ACEP, American College of Emergency Physicians, they started a work group for sickle cell. And there's a lot more backstory to this, but they started something called the Emergency Department Sickle Cell Coalition, EDCS3C3 or something like that. And it includes emergency department physicians, hematology providers. It did include the community voice as well, individuals that had the disease or that were caregivers. And they worked on several priorities. One of the things that was recently launched, I believe last year, a couple of years ago, was their point of care tool for sickle cell disease. And it takes the guidelines that were hematology oncology made, and it makes them in the ED, or the emergency department, emergency medicine framework and lens. They take care of other diseases using these various point of care tools. And so their sickle cell point of care tool, I can share the link after this, goes through the algorithms of how to approach sickle cell disease. And it's quite fascinating that the very first step, the very first thing that they say is the bucket of communication. And in there, they describe the data that shows what you just said, Dan, like the way a person with sickle cell disease has coped with sickle cell in their life impacts the way that they present. Some of them have different coping strategies that are more positive. Some are maybe more maladaptive, but that does impact the stoicism. Anything that you see that you decide is not an expression of pain, that communication part is first and paramount. So it's believe the patient. And so it goes through these literature and just about trust and how you build trust with families and with patients. So communication is first. It's making sure you actually can communicate with this patient and establish trust. And then it talks about, okay, fluids and pain medicine and, all this other stuff. So I'll share that point of care tool, but that's just one start, aside from just the one-on-one interactions with, hey, I know 20-something-year-old so-and-so, she's sassy, she's this, or he's a stoic one, he's a silent guy, but this is some of the backstory. Humanize the patient for them, because think about, there was this initiative about the concept of life being interrupted by pain. These are people that had jobs, friends, parties, whatever the stuff that they were doing. They don't want to be in the hospital. They want to be living their life. But sickle cell is such a horrible disease. The bucket that the emergency department has, let me use the word demonized, and why we sometimes have seen this sad, dysfunctional relationship between the emergency department. And yes, we are picking on them today. Sorry. I could go to hospital medicine too, but emergency department and sickle cell is because they have this nightmare in their minds. With every patient group, there's the group that is impacted by their social determinants of health in a way that makes them overrepresent to the emergency department. So I know that there's some people with diabetes who they don't seem to go to their primary care provider a lot. They're showing up in the ED multiple times, gangrene, all sorts of stuff. The emergency department provider almost becomes their primary provider. That's how bad it gets. But I can do something for diabetes, whether it's I give you whatever I could. But helping pain is difficult because it requires an assessment and your judgment call. And then in this messy world, it requires opioids at times. And I think those are some of the things that have created the messiness. In addition to the implicit biases and the historical components, there's this sense that I don't know how to even help this patient safely. I feel uncomfortable taking care of this patient. So I think I got off track, but my main point is that we have to help the people who don't understand sickle cell realize the importance of communication, and that there's somebody, a human, behind that one-liner, right? There's a person who does not want to be here. I mentioned the nightmare patient, because there are some patients that do seem to want to be in the ED. They're like, oh yeah, I bring me my sandwich, my blanket. They start dictating orders. They're running rounds. They're like, oh, what's happening? Why is that patient? And these are the ones that tend to get the drug seeker label. They know their doses so well, dilaudid 2 milligram, and I need the ketamine. They're saying all sorts of stuff. It sounds frightening to a doctor. And part of that is interpreted by either an empowered patient, somebody who actually knows their disease and is telling you the truth. This is what my hematologist recommends. And then some of it is this messy world of pseudo addiction and the impact of social determinants of health. So if you, like the woman I mentioned earlier, homeless, was living in a shelter, had 3 children, her recent shelter, and I don't understand how this all works, but at the time when I talked to her a little bit more, I found out she was put in a second floor for some reason. I'm not quite sure what type of apartment living this was, but that was impacting her legs. She couldn't make the walk up the flights of stairs and all of this. And that led to why she came to the emergency department. She was in pain because her living situation had changed and it was hard to juggle, the kids, the stuff, the groceries, whatever. And so I think, one, it's horrible that she was homeless too, right? But those are some of the facets that you're seeing. So I love this article that I read where it's like, stop using the word drug seeking and use the word care seeking. Regardless of why they're seeking care, not a high from opioids, not whatever it is that you're worried about in this boogeyman sense. And I want that to be how you view the majority of patients. Addiction exists in every population group, but it's not overrepresented in sickle cell at all. But the way you hear doctors talk about it, you would think half of them are drug addicts, right? But it's a tiny percentage. And in fact, there's data that shows that as America had its opioid epidemic, the numbers of opioid scripts rising, opioid scripts for sickle cell has maintained steady for 20 years because they're a disease that has used them responsibly for years, again, in the right hands. I am not advocating for irresponsible medicine. I don't think you should just give opioids left and right to people without any accountability. But I want to make sure that the pain is recognized as real and you recognize it as suffering and use that to guide the conversations. And it may mean, for some patients, it may mean opioids is not the best thing for them. It may mean something else. But you have to recognize that they're in pain. Otherwise, it's a non-starter. The trust has already been eroded.
These are such helpful things from the perspective of a physician looking after patients with sickle cell. And I certainly appreciate this immense insight that you're able to bring to our conversation today, having lived through these experiences. And I want to thank you for being so vulnerable and sharing a lot of this with us, because the reality is we don't get a chance to have these honest conversations with people all the time about their disease. And from the other side of the table, how has this shaped the way that you counsel your patients when you're meeting somebody with sickle cell for the first time, or someone that you've been seeing for years that maybe, like you, maybe is seeing changes in the way that their disease is presenting or the way that people are treated? Are there resources that you're providing? What sort of guidance do you give them so that we can hopefully do the same for our patients?
Yeah. Ronak, this is very difficult. I've pondered why I became a pediatric hematologist. And the short version is I was too chicken to become an adult hematologist. So again, I commend the three of you. Y'all are, again, especially Dan and Ronak, we're best friends now. Vivek, maybe we'll talk later. But I kept on looking at the nuances. So that patient, the homeless patient, 26-year-old, that's what defined I was like, you know what? Internal medicine is fascinating, is exciting, but I don't think I can emotionally handle this. How do I prevent this from happening? Prevent the patient that people don't believe, prevent the patient's own coping mechanism. How do I prevent that from happening? I felt the pathway in pediatrics was the way. One, it is my personality. I love kids. They're adorable. They're cute. I don't care what y'all say. And I also am okay with parents too. You know, I know adult providing doctors are like, oh my gosh, parents are horrible people. They're another patient. But I loved interacting with parents and the role that you have in helping them feel better about their kids' progress, or sadly, in some cases, lack of progress, just walking through that journey. It's quite humbling. I buttress that to say that the problem of sickle cell is quite enormous. And so when I'm looking at teenagers and I'm in 2024, sometimes I'm like, the world is not yet right. So I'm going to have to tell you the hard facts first. When they're cute and young, I tell the parents, oh, you know, have hope, beautiful future rainbows and ponies are in the future for your kid. And that's my belief. I have to have that hope and believe that we can do better. I want the experience of managing sickle cell to change for the future generation, but it's not quite there yet. There's a lot of advocacy, lots of things have happened. I mentioned a few of the efforts. So when it's a teenager and I'm seeing that they are turning into the potential future disaster patient for an emergency department physician, I'm real. I keep it pretty straight up. I'm careful. I don't want to depress anybody. But I think the families need to know that the adult healthcare system is different from pediatrics. And I'm not sure if us as pediatricians do a good job of translating that, where it's almost like, well, good luck, bye, you graduated. And then there's a whole bunch of unmet expectations on that other side. It's not just about, does a doctor want to take care of sickle cell? It's adult insurance system. Oh, don't go to this provider, go there. How close is the expert that knows your disease? There's just so many nuances in the adult healthcare system. While pediatrics, we try to erase some of those boundaries because of children. So for those that I see are having more of a tough time, either they lack stronger coping mechanisms, they are frequent presenters to the hospital, they have some comorbidities like depression and other things. I want to set them up for success. And so depending on their age, I'm like, hey, you're 18 now. 21 is when we think you're going to be ready to leave. Let's use these 3 years to help address, you know, some of these issues. Let's try to work, because some of the resources that you're seeing on this pediatric side, they may not exist in the same way on the adult side. And because I kind of emphasized how teenagers already get a hint of the adult world, the interactions with nurses change. Again, the 6-year-old, it's all beautiful. Teenagers, you already start seeing medical providers start to question why they're there, or all these other, they're able to pick up on this. So I expressed to them that actually gets worse on the adult side potentially, and that the most important thing is finding your primary doctor, because other doctors may not fully understand sickle cell, but you want to make sure you have at least one doctor in your camp that can be your co-advocate with you too. So I am involved in a lot of transition projects, QI related, because I've noticed that we always say transition is important. Everywhere I go, everybody's like, oh, transition, the teenagers, the young adults, we got to do something. AYA, it's everywhere. but yet it's hard to prioritize. It's a tricky beast. So it's one that I've been hitting my head on the wall on for some time. And I'm happy whenever we do show areas of progress. So the quick summary is that, okay, one, we need to build more independence in our young adult population and teenagers, letting them have more ownership and self-management skills, like building that up, because their caregiver may not be able to advocate for them in the adult world in the same way. And just for various reasons, though, you went away to college, whatever, you traveled, there's just instances where it's not going to be realistic. So how do you set them up for that success? Two, how do we do policy changes and partnerships to make that adult landing softer? That's a long work in progress that involves multiple areas, but that's something that's quite important to me. And I feel we owe, again, this future generation that's still a little bit far away, we owe them how to do better. So is there not enough sickle cell clinics? Are there not enough providers? Whatever it is, we need to start working on those issues. Funding, reimbursement, those are all realities in the adult space. And then I think most people, depending on the type of institution you're able to transition from, some transition at 18, 21, some have the benefit of having a transition clinic, like goes to 26 or something, but you still need help. When you're adulting, everybody knows, right? You got your first apartment, it's a hot mess. And even the most empowered person struggles. Let me not tell you how many bounce checks I had in my early days. I'm sure all of you could relate, right? And I'm like, is it a math problem? What's wrong with my brain? Why? I thought I had money and they said I don't have any money. So all of those facets of being an adult are difficult. And then you're adding that chronic illness on top of that. So I tell the parents, the caregivers, please don't disappear on this child. Just because they turn 18, you gave them a driver's license, they're 21, they're drinking alcohol, they can vote, whatever it is, they can't just be let go like that. I'm not saying baby and helicopter them, but know that they still need a little bit of support because it's hard being an adult. So I think those are kind of the things that I try to work with the families I have now. I tell some parents, sometimes your kid's going to learn from the school of hard knocks, right? Like I found out I cannot stay up all night and study for exams because I'm going to miss the test. But it took the experience of having that pain crisis to let it sink in. And sometimes you might need 2 or 3 of the hard knocks. Some of the parents are like, my son is a disaster. My kid. It's like, this is what it means to be a teenager. This is what it means to be a young adult. Sometimes they do need to make those mistakes. I say I grade on a curve. There are some of the outstanding A+ students. There's lots of solid Bs, but a C is okay. But they do need support. We don't want Ds and Fs, but a C is okay. This kid is doing their best and we need to help them, on their journey. So yeah, that's what I would say. I'm still trying to answer that question. I'm still learning that every day.
Yeah, that's really, really, that was a great answer. I really like that. I think that you're right. Folks there needs to be space for these young adults and teens to kind of figure out exactly what they're doing as a full human being. It almost seems like fellows who know they're going into classical hematology on the adult side should do a rotation with like the peds sickle cell inpatient service or sickle cell clinic and vice versa, just so we can see each other's world because they are different and how we care for patients is different. It's really fascinating, this transitions of care thing. I've been running into it myself in the hospital recently. It's interesting to see.
I agree with you, Dan. I was not teasing when I commended y'all for choosing the more difficult route. I feel like adult hematology oncology is quite a beast. And so I get it. If you specialize in breast cancer and a patient with sickle cell walks in your door, I can't even imagine. And things that are kind of like beyond the human interaction of a doctor-patient are barriers to you getting the best care. It drives me crazy. But no, I can't stress enough how better we need to understand our worlds. You'll hear adult hematologists say, oh, you guys baby them too much. You guys gave them this unrealistic world, and now I have to break reality to them. I think let the reality start on the peds side. We need to show them some mock. Like we had this program where we give them a mock ER, a mock experience, video immersion, all those kind of things to kind of help prep you on how you seek care and what it looks like when you meet somebody that you can tell they don't really understand sickle cell. So how do you navigate care in that space as well?
That's great. Again, the burden really should not be on the patient to have to teach a provider how to care for them. But unfortunately, like you mentioned, it kind of is sometimes right now. We'll work to change that. As far as looking at the future, what are the sort of cutting edge things in sickle cell care that you're most excited about?
I'm excited about a lot of things. One of you had mentioned earlier, oh, thank you for being vulnerable. I will tell people, let me confess, I do this dance between the two worlds. I'm a pediatric provider. I have sickle cell myself, but you'll notice I'm still very cautious with how I share my story. Just because it is difficult going into depths. I know some people have asked me, I can speak about gene therapy and sickle cell on one lens, but it's hard for me to speak about it personally. So on one of my hats, I'll say, I am very excited about gene therapy for sickle cell disease. But as I say that, another part of me is ambivalent or question mark or concerned. And why is that? So I felt this way for some time, even before gene therapy. So let me start with the happy part. In the last several years, we have more industry interest in sickle cell disease, and that has paved the way for new treatments to be explored, including gene therapy, which is quite exciting, right? So for us, gene therapy is like almost like the way AI is right now. It's cool that it's here, but what the heck do we do? What the heck do we do with this thing? I'm scared of AI. I'm like, I've not gone to ChatGPT. I don't even know what it looks like because I'm terrified. But I know it's my reality. It's the future. So I have said to families that the future is now. But just like sometimes our technology surpasses our societal readiness, if you will, Facebook, Amazon, Google, you name all these big trend-setting stuff. None of these people paid me money. They shook our world up, mostly in positive ways, but then they all had these negative repercussions that we didn't know what to do with. Oh my gosh, children are getting bullied, cyberbullying, all this kind of stuff, image. So gene therapy is that kind of weird dance for me, where we're excited that the potential exists to cure, and I put cure in quotes, air quotes, because I can't really say that definitively yet. Nobody has had it long enough, but we're hoping it's transformative procedure at least. But there's also this frustration. So when I give talks to the community, I used to show this slide that is a picture that captions, there's a poem called The Tale of the Rhyme of the Ancient Mariner by Samuel Coleridge. And one of the famous lines is, water, water everywhere, but not a drop to drink. And there's a longer component to that. So I feel this way with sickle cell therapies when you look at me personally, not completely the doctor, but this space where you are telling me and showing me that there's water. You're telling me I should get excited. You're telling me I should jump on the rooftops. I can't drink any of this. I don't see it helping me today. And why is that? There's several things in that bucket. Am I the wrong age, or I wasn't the part of the study, or we have high expectations. It's like when you want to be cured, you want the blue pill and you want all your problems to be over, right? And so resetting those expectations that no, these are complicated cures. These are complicated transformative therapies. And then even the longest running medicine, hydroxyurea, has this boogeyman connotation to it as well, that it's tried several years to break, but there's that. And the new drugs that are out are not the same level of hydroxyurea's impact, meaning hydroxyurea happens to be one of those drugs that do more than one thing for sickle cell, but the other drugs are quite specific. And as you've probably seen or heard, they don't impact sickle cell in the same way. I can't tell you 80% of people are going to have a higher hemoglobin or not have pain because they took this new drug. I have more solid information for hydroxyurea. So to me, the space, I feel like I'm sitting in salt water a lot of times, and you're telling me, you should be happy. You should be ecstatic. So I am excited because the human is crazy. Like when you look at histories and timelines, technology has moved us very, very, very fast in a short period of time. I saw my first, is it color computer? Maybe when I was in college. I used to have the one where it was blue and white DOS, all that kind of stuff.
Right, yeah,
I
yeah.
grew up in that kind of world with the floppy drives and the hard, all that. And now, my little laptop here that's so cute. All of that is impressive. So I know gene therapy is another thing that we're in the first level stage. It's going to continue to be adapted in a way where, one, I hope it can be a reality for more people and not just a small snapshot of the sickle cell population. And it'll be safer and more tolerable for people to psychologically swallow when they're thinking about how complicated it is. So I would say I'm happy that science has engaged in sickle cell space more ardently, and I want to continue to see that happen. I'm also happy that the advocacy space, I consider myself a physician advocate, and that's because I realize the power of advocacy and the power of getting health policy changes in helping a disease. So it wasn't enough. I went to MD PhD because I thought the problem was curing the disease. I was like, oh, if we figure it out, you go to the lab, you cure it, all be well. And until I met that patient that was not believed and not treated, I realized sickle cell is more than that biology part. We have to fix a system that's a societal burden and inheritance. And in fact, it's a bigger beast than the disease itself at times. We've only been speaking mostly from the American lens. I shouted out Nigeria earlier, but that global health space is a whole nother bucket of burden. So yes, I don't want to be doomsday prophet. They're like, oh, we asked you to say something happy. And I'm like, prophesying doom. I think the future is bright, guys. Dan, Rodick, Vivek, the future is bright, but we have to keep in mind, address the elephants in the room and do not repeat the mistakes of our past. The past can serve a good purpose. It can teach us that we got to do better. You got to do better. And so I am hopeful because I can see people doing better now. I see things being called out now. And I see more people like me at the table. Like, you'll see community advocates, you'll see individuals impacted by the disease there. And that has meant the most to me, to see people care. I don't always understand how or why they're caring, but whether it was pressure or an innate sense of responsibility, those things I'm not going to judge. But I'm glad sickle cell matters now, and I want that to stay the case.
Yeah, I think that this conversation to me I've learned a lot today. I do consults for classical hematology. I see sickle cell patients. And some of the things that really stuck out to me today is I haven't truly, as an adult hematologist, a young adult hematologist, but I haven't truly thought about the full experience from childhood to teenage years, the differences in experiences. And obviously it's going to be different for everybody. Having to become an advocate for yourself to make people believe you and feeling that day after day with fatigue, with a chronic illness, feeling different throughout your life, how that impacts you as you go into adulthood. And one of the things that really struck me is that you talked about that term care seeking. And, we always label people as quote unquote drug seekers sometimes, unnecessarily. We have the patients who know a lot about what works for them. They say, hey, look, I need this dose of Dilaudid, this works for me, that medicine doesn't work. And sometimes we think, oh, they just want that drug-seeking behavior. Maybe that's what makes them not itch with their opiates when they have this horrible pain crisis, right? They know their body a lot better than us. And that's really what's really sticking out to me. Care seeking is so, so important. And all of the other social determinants of health, really not just saying, hey, look, everybody, we have a cure for sickle cell disease. Everything's going to be great. Don't worry about it. We have a global problem. We have a huge problem in the United States. We have so many issues with disparities, and really just wanted to thank you for sharing all of that, enlightening me, enlightening all of our listeners who are going to follow this. And I hope that everybody who listens to this really has their own takeaways, really looks into this, looks into advocacy groups, really thinks about doing a pediatric rotation. The pediatric hematologist, if you ever listen to this episode, you do an adult rotation. I think those things are so critically important.
Thank you, Vivek. I was smiling because it's a podcast, so you can't see my face, but I was like nodding my head and smiling as you were speaking. That was so well put. Thank you. The three of you guys are awesome. Thank y'all so much.
Well, thank you. No, unbelievable conversation. I'm so happy that you were able to join us and willing to share all this with us. It's been amazing.